Hello and welcome to this National Pathology Week video. My name is Dr. Susie Lishman and I'm President of the Association of Clinical Pathologists. This series of videos on pathology myths and misconceptions was recorded as part of National Pathology Week 2024, an annual celebration of the vital role that pathology plays in everyone's healthcare. It was developed by the Pathology Alliance, an umbrella organisation of all of the UK's pathology societies and organisations. In this video, Dr. Sarah Wheeldon will explore the statement, "Technology means blood transfusions are a thing of the past."
Hello everyone, my name's Sarah Wheeldon and I'm going to talk to you about, as we've just heard, technology means blood transfusions are a thing of the past. And whilst that might be the case one day, it certainly isn't the case just yet. Next slide, please. So blood transfusion remains a life-saving intervention. And if you could just click through, I think, once more, perfect, thank you very much. So blood transfusions first took place, the first successful blood transfusion from a human to a human was just over 200 years ago. And it's still an absolutely essential part of our work today across specialties. So both within the pathology specialties such as haematology and also across the wider hospital. So we can give blood transfusions to babies, children, and throughout adulthood. In fact, the spectrum is even wider than that because we can give blood to babies before they're even born. So an intrauterine transfusion can be given to an unborn baby from the age of about 16 weeks by giving blood through the mother's tummy through the umbilical vein, which is an incredible feat of modern technology. And so whilst technology might not yet have rendered blood transfusions a thing of the past, one of the things I'm going to talk to you about in the next few minutes is actually how technology is helping us to use blood and blood transfusions in the best way possible. So you can see there, that is a unit of red blood cells. So when a donor, so an altruistic donor, someone who has donated a unit of blood as a volunteer rather than being paid for it, gives a bag of blood, it is split up into its component parts. So we can give red cells to patients, we can give them platelets, we can give them white cells sometimes, and we can give them plasma, so the liquid that all those cells are floating in. And what we're looking at there is a bag of red cells. So if we can move to the next slide, and then one by one, we'll just move through a few of the circles. So if you can just click through them one at a time, that would be really helpful. So we can use blood in an emergency. So patients who are involved in a trauma, in a road traffic accident, in any kind of situation that makes them bleed, we can give blood in an emergency, and that is something that hospitals across the country are set up to do really quickly. Next one, please. Transfusion can be used through pregnancy or for bleeding during childbirth. And next one, please. As discussed, we can give blood in the paediatric setting and also to neonates and even to unborn fetuses. Next slide, or next circle, thank you. The context in which I use blood transfusions the most is for patients who have got cancer and who are undergoing chemotherapy. So we render these patients quite anemic as a result of the treatment that we give. And a way of helping them get safely through their chemotherapy is to top up the blood that they are unable to make for themselves with blood from someone else. Next one, please. Blood transfusions are a hugely important treatment for patients with hemoglobinopathies. So patients who've got sickle cell disease and thalassemia, who often end up on what we call chronic transfusion programs. So the blood that they make isn't effective enough to safely carry oxygen in a way to keep them healthy, and so they get regular top-ups of someone else's blood. Next one. And finally, we can get all sorts of stuff out of the plasma, so the liquid that these cells are all floating in order to make antibody treatments such as IVIG, anti-D, which is an injection given to mothers who are RhD negative, who might have an RhD positive fetus, in order to stop them making antibodies that might harm their fetus. Thank you. Next slide. So our blood donors are hugely, hugely important to us. If we can flick through the next 3 bullet points, that would be super. So there are about 2 million blood transfusions given each year across the UK. Next point. And we need over 4,000 daily blood donations on average to meet these needs. And it's really difficult to predict when people are going to donate, how often they're going to donate. And we see big swings according to time of year, bank holidays, around Christmas. There'll even be big peaks if there is a news story that talks about someone needing a blood transfusion. Things on social media, if a film comes out that involves a blood transfusion, we see increases in the way that people donate, and trying to constantly match the demand and supply can be quite difficult. Thank you. Next one. And there are some people's blood that we need more than others. So ORHD negative blood, you might have heard mentioned, is blood that is sort of the universal donor. So the type of blood, apologies, that should say RHD negative, that anyone can receive. And so we need about 15% of our blood donations should ideally come from ORHD negative patients, but only 8% of people in the population have that blood type. So again, trying to match that demand can be difficult. Next slide, thank you. And interestingly, we are using less blood. So if we just bring up the bullet points in the graph on this slide, we'll see that despite the fact that our population is increasing, and actually the health of our population is in many ways decreasing, and patients are living longer, we're diagnosing a lot more diseases. But every year from 1999 to the present day, we are using less and less blood. And that's for a few reasons. That is partly because, well, it's mostly because we're just using it better. So patients who have iron deficiency as a cause of their anemia, we're getting much better at just giving them iron rather than giving them blood. We're getting much better at treating the underlying cause. We're getting better at not wasting the blood that we have got and using it more appropriately. So patient blood management measures describes exactly that. It's using blood only for people when they definitely need it and not giving them more than they need. So anyone who wants to learn more about blood transfusion, patient blood management is a good thing to Google just to see how we go about making the decisions that we make when we transfuse someone. Perfect. Next slide, please. But let's come back to technology. So it's true, and you can see on the final bullet point there, that there are groups around the country, around the world, who are trying to grow blood in the lab. And one day, it may well be that when someone needs a blood transfusion, we reach for a bag of synthetic blood that has been grown in the lab just for them. And I think it was a couple of years ago that the very first trial was done where red cells that had been grown in a lab were given to a human, and they were absolutely fine. It was a very small volume, and it took many, many months to make this very tiny few drops of blood. But we know it can be done, and it may well be where we end up one day. In the meantime, we're using technology to try and make this as safe a procedure as possible. So there are some conditions that, like sickle cell, like thalassemia, that technology such as stem cell transplants and gene therapy are allowing us to actually cure the underlying conditions such they don't even need blood transfusions anymore. For those people that we can't do that for, we want to make a blood transfusion as safe an intervention as possible. So I'm sure lots of you will have seen in the news or read about the infected blood inquiry. And we know that over the years, the safety of blood has increased year on year to the extent that it is now an incredibly safe procedure. But it's really important to remember what we learned about from that report, that hasn't always been the case. And I'd encourage everyone to have a look at that if you haven't. If we go next slide, please. Finally, and if we just bring up the bullet points here, we're trying to find better ways of using the blood that we collect. So matching blood to patients as closely as we possibly can. So if we've got a patient who has got a hemoglobinopathy and they are having to have blood transfusions every few months, well, we want them to receive the best blood they possibly can and to not develop antibodies to it or to start rejecting that blood. There are groups trying to find ways of making universal components so that everyone can have the same platelets or everyone can have the same plasma so that we don't have to worry about wasting products by them sitting on a shelf for too long and expiring. And finally, we want to tackle things like wastage and optimizing blood stocks. They're not the most glamorous topics, but they're hugely important to make sure that we don't waste any of this really precious resource. Thank you. And then final slide. Oh, and I won't get big data and AI as a topic all in itself, and I know some people are discussing that this evening. But transfusion is absolutely not immune to these technologies that are going to make hugely important steps forward in what we do. Thank you. So essentially, hopefully that explains that blood transfusion is a really crucial intervention to us in modern day. New technology is helping us to use it even more effectively and safely for our patients, and may one day mean that we don't have to use blood transfusions in its traditional form.
I hope you enjoyed learning the facts behind that myth. You can see more of these videos on the Royal College of Pathologists YouTube channel at I Love Pathology.